So as you know, that the prevalence of cardiovascular disease, and particularly heart failure, has been increasing worldwide. Not only do we have an aging population, but we have had a higher prevalence of risk factors, as you all are well aware of, obesity, diabetes, and hypertension. In fact, when you look at worldwide, there are documented 64 million cases of heart failure. That's 8.52 cases per 1,000 inhabitants of the world. And if you look, 51% of these are severe heart failure, and they account for 9.9 million years lost due to disability. And the current economic burden of heart failure is $346 billion. In fact, in the United States, acute exacerbation of heart failure is the leading cause of hospital readmission within 30 days. And obviously, frequent hospital readmissions is associated with increased mortality, poor quality of life, and increased healthcare cost. So that just puts it into context why we're even having this conversation about heart failure. So we are very much interested in trying to prevent these patients from getting into the hospital. So this concept of pressure-guided heart failure therapy really came into being. And if you look at this, what I want you to take away is the fact that the day of hospitalization, which is 0, look at, if you go as far back as over 21 days, symptoms can actually start, and we have the opportunity to prevent a heart failure hospitalization almost up to 25 days prior to their hospitalization. And we can avert that, not only with the appropriate medical therapy, but that gives us a window of opportunity to make an intervention. This slide actually talks about the pathophysiology of congestion. So if you look at beyond 20 days, minus 20, that's when you first start seeing filling pressure increase. And then as you go up the curve, more than 21 days, you start seeing the autonomic adaptation that the body goes through. There's intrathoracic impedance changes that occur. And if you wait till weight change, which is what we typically do clinically, we're really close to symptomatology, and then hospitalization is a very short time away. So typically what we have done is waited for patients to develop symptoms, but if you look how far that is from hospitalization, we are having a missed opportunity to be able to intervene on these patients. So there are many ways that we can monitor these patients. There's the symptoms and vital signs, as we just talked about, by doing weights, which we tell patients, when you go home, do a daily weight if you start noticing your weight go up. But typically, by the time patients let us know, they're usually already in trouble, and it's difficult to sort of intervene. You have the lung congestion, so the thoracic impedance that I mentioned is the other opportunity, but going further down is the hemodynamic opportunity, and this is what we're going to focus on, is the pulmonary artery pressure measurement. In the past, just to let you know, the non-invasive monitoring systems such as telehealth, all of these trials really fail to really show a big difference. So the non-invasive monitoring has never really been that helpful for us. And so the idea of CardioMEMS, which is a wireless pulmonary artery pressure monitoring system, which is implanted usually in the left pulmonary artery, either in the inferior or the lateral branch, and that allows us to then monitor pulmonary artery pressures. So this is the picture A is a chest x-ray that shows the CardioMEMS sensor, which is in the branch of the left pulmonary artery. If you look at B, that is the sensor, which has 2 nitinol loops, and you can see the size. It's actually quite small. And then down below in C is what the pressure, PA pressure reports look like. Now, the system, so the sensor gets implanted, and the patient then has to use this pillow to guide proper position, and basically by laying down on this pillow, they can interrogate the sensor, and that data then is directly sent over. And you get this PA pressure trend data. So it allows us to do hemodynamic monitoring using this wireless system, and it gives us 18-second measurements of the systolic, diastolic, and mean PA pressures. So at implantation, you can get a baseline. If you have a patient at dry weight, you know what their PA pressures are, and then you can utilize this to monitor them going forward. So the CardioMEMS trial device actually came into being, and there are many, many trials. The Champion trial in 2011, and as you can see, those trials go from 2014, 17, 19. The most recent one is the Guide Heart Failure Study, And if you look, there are multiple study designs. There are single-arm studies, there are propensity match studies, and then there's the randomized control trials. The CHAMPION being the first one, and the GUIDE heart failure, which is the one that was done during the COVID era. I'm really going to focus just in on those randomized control trials. The CHAMPION trial, which was the original randomized control trial, had about 500 patients. These patients had the PA sensor placed and monitored, and then they looked to see if there was a difference in the hospitalization. The blue graph illustrates pulmonary artery monitoring versus control, which did not have any device, and basically what you saw was a reduction in terms of heart failure hospitalization. In fact, when they went out to 15 to 18 months, what you saw was a decrease in the heart failure-related hospitalization, almost 37%. Now, the various study did show that with utilizing this, we were able to reduce the PA pressure, so there were reduction, and you see the supporting studies for that. Hospitalizations were definitely reduced, not only in the study that I mentioned, but also these other supporting trials showed that there was decrease in the hospitalization. Now, the one bugaboo for heart failure is that it's easier to do that when you're volume overloaded with reduced heart failure. But what about the HFpEF patients? They are a large burden of our heart failure patients, and this has shown some benefit in these HFpEF patients also. And then certainly if you do a quality of life assessment on these patients, across the board, the patients reported outcomes that they felt better because they could breathe better, and so improved quality of life. I'm going to touch mostly on the GUIDE heart failure. This was the very last, the largest randomized control trial with 1,000 cardiomems that were placed in these patients. So 500 of the patients got cardiomems. The other was usual care. And what they were looking for is a primary endpoint of all-cause mortality, heart failure hospitalizations, or urgent heart failure visits. If you look at the conclusion here, the conclusion was that there was no difference in the CV outcomes among stable outpatients with chronic heart failure when comparing management on PA pressures using cardiomems. Now, their conclusion was also that the COVID pandemic may have contributed to this overall negative finding. Now, let's look a little bit deeper at that. And if you look at the pre-COVID-19 analysis, which was the primary endpoint up to March 13th of 2020, there was actually a 19% reduction in the primary endpoint in the treatment group. But at the overall, at the completion of the trial, there was a 17% reduction, but it missed a statistical significance. So what they saw was an improvement in the pre-COVID analysis, but which did not pan out in the post-COVID analysis. And so take it as that really, this being the largest trial, we didn't come away. So it depends on what camp you're in, whether you believe the pre-COVID analysis and that COVID skewed it, and there's actually a benefit. So again, going back, what about other therapies? Because pulmonary. So I'm going to go back, and because the question that Dr. Bang asked me to answer is, does cardiomems work? Well, it certainly works, and we've used it at our center. And I will tell you that originally when the device was put out in the marketplace, we used it a lot more. I will tell you, in the era of the quadruple therapy for heart failure, patients are feeling better. There is some hesitancy to have patients be getting an invasive device. And by the time I think when we are offering it, some of those patients are much further along the spectrum, and then they don't want something invasive. We are centralized. So I don't think we're using it as much as we originally were. And I think that in the last several years, I know centers such as San Diego, close to me, is using a lot of them, but we're not using them as often as that. Now, one of the reasons I mentioned to you is the invasive piece of it. So this idea of thoracic impedance brings up the next device, which if you look on this, the implantable fluid pressure device goes between 20 to 30 days. That's where you're getting the information. But what about earlier than symptoms, but not as early as hemodynamic PA pressure monitoring, the intrathoracic impedance? So there's a heart failure management system that's out. This is a microcore device. It's a non-invasive water-resistant sensor that can be worn by a patient externally on the chest, as is shown there, and it can be placed and continuously records the data, including thoracic fluid index, heart rate, respiratory rate, posture, and heart rhythm. And this is a non-invasive a way of monitoring pulmonary fluid measurements. And there is an ongoing trial that is going to be presented this coming year, the results of that. So I think there is a lot of enthusiasm for the non-invasive component of it. I do think the CardioMEMS, the question was, did it work? Yes, it works. Do we use it as much as we should? We certainly don't in our institution. I'll be curious to know if any of the panelists are using it more than that. So I would say, given the burden of heart failure in the world and the economic implications, there's an imperative to treat these patients early and really prevent the hospitalization. I do think that the new guideline-directed medical therapy, if done in the right doses and making sure that is really making these patients feel better so there's less of that impetus for doing the implantation. I think non-invasive techniques are being ushered in and could really change the landscape of monitoring techniques. And I guess the question in a place like India is the ultimate treatment really the prevention of heart failure, going back as far as making sure that we talk about lifestyle factors, making sure that we're really going after hypertension treatments, diabetes treatments, all of the things that can lead to heart failure down the line. And would that help us? So maybe some of the focus really needs to be on the real primary prevention of heart failure. So I'm going to stop here. Thank you very much for your attention.